Well, thank you both for those fantastic discussions. Are there questions from the audience at all? So I have one for you, Dr. Jamal. You mentioned in the program that you have that it does traditional measurement techniques, and then there was some mouth thickening that was seen. What does it look for if it's not using what I would call traditional measurement techniques? What are those?
Your question is about what the AI is looking at, or
yes, what is the AI looking at? Because you pointed out that traditional measurement techniques can sometimes be flawed. And so what is it actually, what is it?
Well, so this is a very interesting question. It's about how these algorithms are trained. And even when I've tried to read the engineering papers on how they're trained, when it comes to the actual development of the neural networks, the engineers themselves don't really even know exactly how it learns. But I think it's all off of pattern recognition. So it is likely that the algorithm is examining every speckle that's on the clip. So it's watching the movement of every speckle, and it's looking for patterns. And it's comparing the patterns of what it sees to its library of known cases. Dr. Ansanjani he demonstrated that on an elementary level of how AI could differentiate between apples and oranges and bananas. So similarly, that's what it's doing on a more complex level. And I do think that it examines everything that humans examine, except we do it sort of intuitively. After you've read 20,000 echocardiograms, it's just happening in your mind in the background that like there are certain patterns that we look for. Like even when I look at the left ventricular myocardium and I feel like, oh, it's a little denser or it's a little more sparkling than I would expect, that's just based on having read thousands of echoes. And so I think that's what it's looking at all of that. It's looking at the movement of the tissue. So it doesn't need to do Doppler. So what I meant by it's not doing conventional methodology, like our eyes cannot measure like velocities in milliseconds. That's why we use Doppler to evaluate the speed of tissue or the speed of blood within the heart. But the algorithm can do that without Doppler. It doesn't need Doppler. It can look at it and it can time it. So I think it's taking all of those things that we look at and we consider that what we consider to be a gist of what an image looks like, and it's able to analyze that in a more systematic fashion.
Great. No, thank you. And then are there questions at all? So then, Dr. Arsanjani, you mentioned using some of these modalities to follow therapy as well, to follow people. So just in general, how frequently do you use echocardiograms to follow individuals? And that's for both you and Dr. Jamal, too.
We get routine echocardiograms on patients who are on therapy. I mean, the problem with the echo is that you clearly see, if you see people that are improving, the changes take time, right? Again, it's taking that individual number of years to get to that point. In 6 months, you might not see a significant change compared to what it was. And from an imaging standpoint, I actually looked at our internal database of how many patients actually had serial MRIs to look at their response. We only had about 54 patients that had serial MRIs. So we don't routinely do it. Again, it's not cost effective. A lot of times people look at other markers. You look at a 6-minute walk, you look at the NT-proBNP level, you look at how the patient's feeling. But I think that as different therapies become available, people will look at this a little bit more. Mm-hmm.
Yeah. Great.
I think I will say that people talk about the echo, and patients, of course, understandably ask, does my heart look better after they've been on treatment for a little while? And the honest truth is, on an echocardiogram, it's pretty rare that we see significant improvement in the anatomy. So I think the wall thickness, there are reports, there's publications saying that the wall thickness will improve, or maybe you'll see like a millimeter improvement. But 1 millimeter on echo is negligible. You could just be reading it a little bit differently today versus tomorrow. So in true practice, I can't think of more than maybe 1 or 2 cases where maybe I reported that the LV wall thickness actually improved a touch by 1 or 2 millimeters. It's really, really rare that that happens. On the other hand, I think eventually, I think we will see some feedback from research involving cardiac MRI, because extracellular volume is truly able to measure disease burden in a fashion that's much more sensitive than what echo can look at. And so from that and from PET, I think these modalities offer more promise for disease, for tracking of disease progression and regression of the disease.
Great. Thank you again. Are there questions at all from the audience? Well, thank you both very much for these very enlightening discussions. And now we'll get on to the debates.